So now we're going to talk a little bit about the stages of the journey, and I'm going to turn it over to Dr. Chappell to talk a little bit about how to think about the different stages and what to focus on. I know there's a lot on this slide too, but I know he's going to talk through how to think about the different stages of the journey.
I do love to talk, and I really like this slide. I feel like being in the fertility area in the field, I see a lot of patients, and I feel like one of the most overwhelmingly the most common thing I hear after a consult is, why didn't I come talk sooner? I can't believe we waited 1 year, 2 years, 3 years, 7 years before having this conversation. So I really like how front thinking frame is and saying, we need to get this information out there sooner than later, so people are thinking about this on the front end, like they make any other decision that has a major impact in their life. We should think about fertility like we think about all major decisions. And so I think talking about the stage of the journey makes a whole lot of sense, because I find many patients are asking questions too late. So if we're in that kind of prep phase of, I don't really know, I think I'm just kind of getting started with my adult life, and I think I might want a family. I think I might not want a family. Who knows? Then this is a time where you could be thinking about what pregnancy may mean for you. Where are you with your goals? What are you a kind of person that always saw yourself with a big family or a small family? Do you have other medical conditions that you need to think about? How would they affect your pregnancy, and how would they affect is this pregnancy going to be a high risk or not? Some people know they have multiple sclerosis or rheumatoid arthritis or migraines or fill in the blank. That's going to have an impact in how you experience pregnancy. You need to be thinking about that and asking questions to your providers about that. This is the time to just initiate a conversation with your OBGYN or your primary care physician and say, hey, I'm still at this phase of my journey. I'm not trying to get pregnant yet. That's maybe a few years down the road, but I know that you're treating me for X, Y, and Z. What does pregnancy look like with that? How does building a family matter in this regard? Are the medications that I'm on pregnancy safe, or are we going to have to change those up? Those are really good questions to ask early on. Good places to go for tips would be ACOG, ACOG, the American College of OBGYN, or ASRM, the American Society of Reproductive Medicine, has an awesome website called reproductivefacts.org. Excuse me, fantastic website just to go do a little shallow dive. And those are good, safe places that are probably a little bit more, they're more reputable, they're more vetted than TikTok or the Gram. So I think those would be the places that I would start. As you just think about what might pregnancy look like for me, and how many times do I want to be pregnant? And then as you kind of get your head around those, we're starting to think about your plan, starting to think about timeline. Don't forget that it's not just pregnant baby, pregnant baby, pregnant baby. It takes 9 months to make a baby, and then it takes 6 to 24 months to kind of reset your body to get ready to make another one. So if you want 18 kids and you want to wait till you're 35, those two things do not go together. You kind of have to build in your plan to a realistic timeline. And then at the same time, again here, and I think this is where Dr. Eskew's points really came into play, think about your health. This is where you have the opportunity to kind of optimize your chances by making your body as ready to be pregnant as possible. And I think that, to Dr. Eskew's point, we don't do a great job of thinking about health as it relates to fertility. Fertility is kind of one of the vital signs. If your blood pressure is good and your pulse is good and you're not running a fever and you're having regular cycles and you're fertile, all those things point to the fact that your body's in line and in good homeostasis. So be thinking about your nutrition and your diet. Be thinking about your exercise, sleep, stress, any vices like smoking, drinking, all those kind of things. How do they impact your fertility? Another good conversation, another good opportunity to engage in your primary care physician and say, hey, I like to have a glass of wine once or twice a week. Is that going to be a problem if I'm ready to start having a kid in the next few months? Or, I'm really having some trouble sleeping. I think I'm snoring. Do I need to be screened for apnea or things like that? Or, hey doc, I'd like to lose 15 pounds. What's the best diet for me in my story with my metabolism? And you can kind of use this prep time of I'm about to jump into this trying phase to optimize your general health. And that's just going to help your body work better. When your body's working good, your brain is seeing that and saying, okay, let's send down some signals, let's grow an egg, let's release an egg, or hey, let's send some messages down to the testicle to make some good sperm. And so body functioning well, fertility is one of the first things that rises up. When the body's not functioning well, fertility is the first thing to go. So I would be proactive about thinking about those things. And now as we kind of enter the actively trying phase. This is, some people are like, track, ovulation predictor kits, basal body temperature, chart everything, Creighton model, da da da. And then they always say, but don't be stressed. And I just think that those two things are completely incongruous. And so I think you need to find a healthy balance. There are about 300 ovulation apps out there. I loved when I first started this in fertility. There was only two. It was Glow and it was Flow, and it was great. I knew how to use them both, and so I just hand over your phone. But now there's 300, and I have to learn a different interface with every patient. But use an app if you like using an app. If you like using an old composition notebook with some inspirational message on the front of it, use that too. But tracking your cycle in one form or fashion is a good idea. If you like doing basal body temperatures, that's okay. That's my pet peeve, but it's okay to do that one. If you like using ovulation predictor kits, that's expensive, but okay. If you want to just record the first day of each of your menstrual periods, that's enough. That's enough information over the course of 6 to 12 months to have a really good idea as to how your brain and your ovaries are talking, and it's free. So just tracking cycles in some minor way, maybe considering a symptom journal if you have pelvic pain, or if you have heavier bleeding, or if you just have something that you sense that you feel that may be off, writing those things down as you track those cycles. That one sheet of paper at a medical visit tells us almost everything we need to know. It is valuable. It doesn't need to be every temperature you've ever taken. It doesn't need to be every LH surge, and it doesn't need to be a picture of every OPK. We certainly get those. We get the binder and we go through those, and that's information. But it's also maybe a little bit too much information because you can be so stressed out. So find the balance, track what you can track, and just kind of be consistent with that. And again, continuing to think about your health in general. Actively trying, Dr. Eskew also touched on this, it's 6 to 12 months and before you need to be asking questions. But that's if everything is going perfect. So let's move into like when should you say, okay, enough is enough. I need help. Again, this whole process, you're engaging your primary care physician or your OBGYN. You're talking to them about getting ready to try. You're talking to them about getting amped up and how to try. And then you're actively trying. But at some point it's not working. You got to go talk to a more specific specialist like a reproductive endocrinologist. It's 6 to 12 months. If you're over 35, don't wait longer than 6 months. If you're under 35, you can give it that full 12 months. But that's if everything is going good. If you're having a cycle every month and you're feeling good and you're tracking and everything makes sense. If you're not having regular cycles, something's off with libido, you're having very heavy cycles or shorter cycles, or you're sensing that things aren't exactly working, don't wait a year. Your check engine light is on. Go in sooner and have those conversations sooner so we can see, is there a problem? My favorite thing to do is to have a conversation with someone and say, oh, well, actually, you're probably ovulating around this day. So go away, and go try on your own for 3 months doing it this way. That's a perfectly reasonable, okay conversation. They don't necessarily need treatment. They just needed to push in the right direction. That's an okay thing to say, but it's less okay for someone to come in after a year of trying, doing it completely wrong, and having wasted that precious year because time is over. Red flags, the things that if I saw these, I would say probably have that conversation nowish. Let's see. So like, again, if you have just no signs or symptoms of ovulation, if your cycles are very irregular, I have some patients that they haven't had a period since the last president, and yet they wait a year before having a conversation like, hey, you're not going to get pregnant if you're not ovulating. Let's talk about why you're not having cycles. Shorter cycles are one of the things that worries me the most. Shorter cycles can be a sign of egg reserve going down faster than it should. Because if you're ovulating quickly, then you're having shorter cycles, more like every 3 weeks as opposed to that every 4 weeks that you read about in the books. So if you're having cycles every 3 weeks, that can be a sign of irregular ovulation or unstable lining. And that can be a sign of a lower egg reserve. And that conversation needs to be had sooner than later. Persistent pelvic pain, that can be a sign of a number of things. It's very non-specific, but it's worth a conversation. And pelvic pain is very annoying and very debilitating. You deserve a conversation sooner than later. And then the final thing I'd say is that you are your best advocate. So if you're frustrated with not getting the answers you want, either on social media or from the person that you're seeing, or from your friends or from your family who say, don't worry about it, don't stress, just keep trying. If you're frustrated and you want more answers, you want more guidance, that's a totally reasonable time to have a conversation. To Dr. Mbe's point, it's easier than ever to get on a Zoom call with 4 specialists, and me, to have, a quick little overview of what's going on and what you can do better. So don't hesitate. It's just too easy these days. And then, yeah, and again, keep in mind that it's not realistic to have 10 babies in 2 years. This is an ongoing process, and it's not, everybody says, oh, I got pregnant that first month. That's not always the whole story. It doesn't happen overnight, but it can happen according to your plan, as long as you take a few minutes to make that plan.
Yeah,
I think I'll stop.
That's a great clarifying point. That was something that I didn't even think about. Even the 9 months to create a baby wasn't something that fully occurred to me either. So I think it is something that often gets lost. Dr. Chappell, I'd be curious, for those people that are exploring going to treatment immediately, those that are in a same-sex relationship, want to explore reciprocal IVF or surrogacy, et cetera, what advice would you provide on that front? Like how soon is too soon to have those conversations, or what does that process look like too?
Yeah. So that process, I mean, so if you're either a single mother by choice or same sex, or you were born without a uterus and you need a gestational carrier, or you have some contraindication to pregnancy and maternal fetal medicine has said you can't get pregnant, you need to probably consider a gestational carrier or a surrogate. Quick sidebar, a gestational carrier uses your eggs and your partner's sperm to carry the pregnancy. A surrogate uses their own eggs and your partner's sperm to carry the pregnancy. That's just a little sidebar. Yeah, those conversations need to happen immediately. Just like someone that hasn't had a cycle in months or years, clearly there's an issue that needs to be addressed. Clearly there's an issue that needs to be addressed here. This person needs extended or elevated care. That conversation needs to happen. No one has high blood pressure and then waits a year. If they know they have high blood pressure, they come in for medical care. If you know you need a gestational carrier, or you know you need sperm donor or egg donor or some sort of uterine help in the form of gestational care or surrogacy, have that conversation. And I do think if you know you need it, but you know you don't want it for another 2 or 3 years, like, so let's say, 23-year-old woman who's married to her wife, and they know they want kids when they're 27 or 28 or 29 or something like that because they want to finish graduate school together. I still think it's reasonable to have that conversation at 23, because what you want to know is, what can I be doing to prepare for this? For someone that comes in at 23 or 24, maybe they have endometriosis and they have a lower egg reserve, and they might want to consider going through their procedures now to freeze eggs or embryos now, so that they can actually have a good shot at 27 when they're actually ready to carry, for example. So I think when you know that you need that help, have that conversation. You don't have to wait until the day that you want to be pregnant. That's a common mistake.
It's a great clarification.